always, exercise, but, you can't out exercise a bad diet. Your cholesterol went down by eating bacon and eggs and ground beef. And I was like, yep, it dropped a lot. It's counter to what, the food pyramid has been telling you since kindergarten. A lot of people don't realize how much hyperinsulinemia and just your diet affects everything in your life.
So welcome. Today we have with us David Farr, one of our providers at Revero. David, take a second to introduce yourself.
All right. I'm David, nurse practitioner based out of Alabama. Went to undergrad and grad school at UAB, which is the major medical center for the state of Alabama and does in the Southeast. And finished NP school in 2011. Moved back to my hometown in 2012 when a job kind of fell into my lap that I didn't really anticipate, but it kind of came out of thin air, and it was the right time for life to kind of move back home. And so I've been working urology since 2012 in the clinic and in the hospital, seeing patients, both acute and non-acute stuff. My NP is in adult acute care, so I'm meant to do both inpatient and outpatient type stuff.
Okay. And so, for those that don't, urology, correct me if I'm wrong. I rotated to urology when I was in, I think, medical school. And it was mostly a lot of old guys and a lot of prostate stuff. Is that pretty much what urology is?
That's what everybody thinks it is, but they forget that women have kidneys and bladders too.
Right. Sure.
And I would say majority of our over 50% of our patients are men, but we do have, probably 40% of our patients are women, maybe higher than that, just because women have urologic issues as well. But everybody knows urology is erectile dysfunction, prostate issues.
Right. Interesting. You are, as I mentioned, you are working with us at Revero. Obviously, we approach things a little bit differently, a lot differently than the standard practice is for sure. And let me just ask you, just with regard to the urology stuff, because, whether it's putting people on erectile meds or doing, setting people up for TERPs, and I don't know if you do some of the cystoscopy stuff, but I think some of those issues, probably a lot of those issues, could be improved upon with proper nutrition, even in the urology specialty. Is that a fair statement?
Oh yeah, absolutely. Yeah. So, obviously erectile dysfunction, a big trigger for that, diabetes. And that's a big focus of Revero, is getting folks off these diabetes medicines and kind of reversing some of the inflammatory damage. And then a lot of people don't realize a lot of overactive bladder. Some of these diabetes medicines, the way they work is they make you pee your sugar out. And so recurrent UTIs and frequency and incontinence and things like that. So a lot of my patients that have those symptoms, men or women, I look at their medicine list. I'm like, oh, well, you're on this medicine. And the way it works is it makes you, when your sugar's up, it says, hey, I need to pee and make a lot of extra urine to get rid of this sugar. And so then that contributes to their urgency and their frequency and their, incontinence. And, that can lead to urinary tract infections more predominantly in women. So yeah, I do have the dietary discussions with patients, not as in depth as I would like to, because I just don't have the time to, because we're super busy. But I do kind of try to direct some lifestyle change into my conversation with some of these patients.
Yeah, I think the meds, the SGLT2 inhibitors, which basically make you pee off all the glucose. And one of the negative side effects is sometimes people get, because there's so much sugar in their urine, they get a fungal infection in their genitals, which ain't a lot of fun. And you get things like Fournier's gangrene, which is absolutely horrifying,
Don't say that to a urologist.
Yeah, no, I can remember being in the OR when that stuff was going on. It was just awful, just walking by the room. It was such a horrible sort of thing. Yeah. There is also, BPH. That's a super common, like I don't know what percentage of guys over 60, 70 have BPH, probably hell of a lot of them.
80% of them probably, to be honest with you.
And I do think that, and I may be wrong on this, but I think that probably nutrition plays a role on prostatic hypertrophy. And I think it's probably probably related to overexpression of insulin. It's just causing stuff to grow, like it causes the belly to grow fat and the skin tags and all the other lipomas and all this other stuff. So I have seen some guys on Carnivore see that their prostate BPH symptoms have gotten better, which is probably interesting.
That'll be interesting. I need to look into some of the literature, see if anyone's even doing any research into that.
Well, I mean, there is a relationship between hyperinsulinemia and BPH. I mean, you can find literature on that, and it just it makes sense. I mean, it's abnormal growth, which is what's causing that. Okay, let's switch over to how you found Revero. What inspired you to want to do this type of stuff?
So a couple years ago, during my routine physical that I have to get every year with my insurance and stuff, my lipids were really high. Well, not really high, but higher than they should have been. And I hadn't been eating right. I've always been active. I've always exercised, but you can't out exercise a bad diet for the most part. And so I'd come across you on, I think, Joe Rogan's podcast, and I've never been a huge vegetable and fruit person anyway. So to be honest with you, going carnivore wasn't too terribly hard for me in general. So in January of 2023, I told my wife, I said, I want to cut out, I'm just going to go carnivore. She's like, what? And she's a nurse, so she's, knows some medical stuff. And I was like, it's better than eating junk, which what I was doing. And, it makes sense that you keep your sugar low and all this, a lot of things can get better. And sure enough, 6 months later, when I had my labs rechecked, my triglycerides had dropped by 70%. My HDL went up. I lost some weight. I was more active. I was, going to the gym more, working out better, all that kind of stuff. So that's kind of what got me involved. And then, I forget, and that's I'd heard about your company, and so I think I was just kind of stalking the website about, are they hiring? I think I might have come across on LinkedIn or something like that, and applied and got the job.
Yeah, we're thankful that to have. We've got some wonderful providers that most of them have had a personal experience, like me. I mean, you have a personal experience in your own health. You make because most people, until it happens to you, kind of like it's just people talking. We don't really appreciate that. And so, in that capacity, it's a different, like you said, in urology, it's probably a grind. It's probably a rat, hamster on a wheel. Just boom, boom, next patient.
Yep.
And I know how it is. I was in a surgical subspecialty as well. And it's just,
right.
You're just flying throughout your day and you don't have time to have these discussions. How do you like having maybe the time and the opportunity to take the time with the patients and actually get into this stuff?
I mean, I think it's really great because a lot of people don't realize kind of how much hyperinsulinemia and just your diet affects everything in your life, from your mental clarity. We do a lot of testosterone, and that's a huge thing with guys and testosterone. If you're obese, you're going to have low testosterone. So the way to lose weight is to clean up your diet and move more, and that can naturally raise your own testosterone. So having the ability to kind of have a 30-minute conversation with a patient about kind of what the medications that they're on and how changing their diet can get them off these medications and improve some of their somatic symptoms. It's great. And I mean, and also the ability to kind of text back and forth with patients really helps too, to kind of have a live stream conversation with the patients instead of an every 3 month or every 6 month appointment.
Yeah. I mean, that is the thing, as I mean, it's because medicine is so busy and it is very often hard to get follow-up appointments in a timely fashion, and things have to move at the pace of, we kind of figured out, I think we'll see you in 6 weeks. I'll see you in 3 months, depending on the acuity of what the issue might be. And, with nutrition, things happen sometimes within days. I mean, you probably see, you take a diabetic who's poorly controlled, you switch their diet, and 3 days later, their friggin' med needs are cut in half, perhaps. Is that a fair statement?
Yeah, I mean that, and I actually, to be honest with you, I haven't had a whole lot of diabetics as my patients with Revero, but blood pressure, I had a guy, he signed up 2 weeks ago and he's already off one of his medicines. I mean, so, you'll see it with that as well.
Yeah, for sure. And that is, and this is something that a lot of people don't understand. Particularly people like hypertensive. There are so many classes of antihypertensive drugs. Calcium channel blockers, angiotensin receptor binding blockers. There's,
Mm-hmm.
calcium,
Beta
diuretics,
blockers,
beta
all that.
blockers, on and on and on, ACE inhibitors. And I mean, there's a way. You just have to take this stuff off, and you can do it and if you don't come off this stuff appropriately, then you might end up with a hypotensive episode. Your blood pressure drops too low, you whack
Mm-hmm.
your head, and all that stuff. Uh, you know, um, so I think there is some important, like I said, your grandmother can tell you what to eat, and people say, well, why do I need a medical team to support me to tell me what to eat? You don't necessarily, but if you have some of these medical conditions, which do require some level of
Mm-hmm.
skill to manage appropriately. And then the other part is, this is the part that I found really, really that I'll tell you, I struggled with, because when I was, 10 years ago doing my orthopedic stuff and figuring out, hey, nutrition is really important. I like to have a discussion around that. No support, no time to do it, no incentive. I literally disincentivized from doing that.
Mm-hmm.
And now, I mean, you obviously you've got a whole team around you. You've obviously got what you provide as a medical expertise, but then you've also got the coaching staff and then all the support team that helps with that. And that's got to be, makes it easier. Is that fair to say?
Oh my gosh, the health coaches are unbelievably talented. Some of the things that they talk to the patients about, that they recommend, some of like just deep breathing techniques and things like that, because a lot of people have stress and anxiety, and that can be triggered by poor diet and elevated cortisol levels and things like that. I mean, the health coaches are the rock stars to me of Revero, to be honest with you. I mean, the things that I see in the conversations with the patients that they do is amazing, as far as like the diet control and the recommendations and the eating windows and the protein intake, and kind of how everything is fine tuned per the patient for what they want and what their goals are.
Yeah, and that really, I mean, the way medicine's set up is a physician doesn't have time to do all this stuff, and like I said, you can oversee it and make sure that the medical side of things are going well, and deprescribing appropriately, and checking labs when necessary. But it really is, and this is a thing that I've found, a lot of these people that come to us, they've been through the medical system and they haven't gotten what they want. They're still hypertensive.
Mm-hmm.
Some people are on blood pressure meds for 30, 40, 50 years, and they're always hyper. And you go, hey, you can make a dietary change and you don't need this stuff anymore, which is kind of interesting for a lot of them, not all, but many.
Yeah.
Do you find, one of the things, like most people that come to the urologist, I imagine, just like when I was an orthopedic, they don't want to be there. They
Right.
have to be there because they got a problem. They don't want to
Mm-hmm.
be there. No one wants to have erectile dysfunction. No one wants to have prostatitis or
Mm-hmm.
whatever, cystitis or something like that. And so they come to you grudgingly, and
Right.
you're like, what can you do? Can you give me a pill or whatever? Maybe you can, you can relieve some acute suffering occasionally. But the patients that come to Revero generally want to be there, and they're motivated to change. It's got to be refreshing as a provider. Correct me if I'm wrong on that. Hey folks, it's Dr. ShawnBaker here. Hey, if you or someone you love is suffering from chronic disease and you're tired of just managing symptoms with potions, pills, and procedures, I want you to check out Revero.com. Our team of dedicated professionals is committed to tackling the root cause of your issue and finally getting you healthy. Hurry up, though. Our spaces are filling up very quickly.
Oh no, yeah, yeah. I mean, it's patients that want to do the steps to come off of medications, because take BPH for instance. Take the benefits that you can have with it, from cleaning up your diet side. BPH is a blockage, and it's an easy way to fix. You unblock the prostate. Well, a lot of guys just want a pill, and it's like, well, that's not going to fix the problem. It'll improve your symptoms, but I advocate for deprescribing in my practice. I'm like, look, you've been on this medicine for 15 years, and now your primary care sent you here to fix the problem. Let's fix the problem, and you can come off one or two, or sometimes even I have some guys who are on 3 different prostate medications, and they just that's all that a lot of people just want. They want to do the easy stuff too, and the diet's not easy initially, but once it becomes a lifestyle, then it's just day to day eating.
Yeah, and I mean, talk about unblocking. That's what that TERP procedure is,
Mm-hmm.
and I don't think any guys are looking forward to having a TERP.
You'd be
Like,
surprised if it
well, I
gets
mean,
a
if
catheter
they're
out of a guy.
yeah, I mean, I guess if they're in pain and uncomfortable and can't pee, but I mean, it's just like, man, you got to stick what up my what,
Right?
and it's
Yeah.
just like, you know, it's got to be not super exciting for most of them. But what? So you say you see a lot of hypotensive patients. What about patients struggling with obesity? Is that a common thing you see?
Talking about in Revero or just
Well,
in?
probably both, but yeah, in
Well, yeah, I see
Revero
them
for
in
sure.
both. Yeah, Rivera actually, I was messaging with a patient last night that he was, I think he was on 4 blood pressure medicines, and we're about to. One of them he already stopped because he just took it on a PRN basis, and we're about to get him off his diuretic. And he was knocking on 500 pounds, and he's lost some weight. And I actually told him I was going to be on your podcast. And he's like, well, tell Dr. Baker I want to do it when I'm half the man that I was when I started. But we're about to get him off, get him down to 2 blood pressure medicines from 4. And been a road with him because there were some times I'd get the alerts that his blood pressure was 190 over 110. I was like, oh, so I'd call him and say, how are you feeling? That's the other thing about Revero is you have like almost nearly instantaneous communication. And when they're documenting their blood pressures or their blood sugars, in those situations, you get an alert saying, "Hey, Joe Smith's blood pressure is really high. Call the patient and kind of make sure he's doing okay." That's what we do, and so that's kind of the perk of Revero in general is the fact that you have, you know, within 24 hours, you're going to have communication with somebody from the team to make sure that, hey, your blood pressure is really high. Did you take your medicine? Are you eating right? Did you sleep right? Are you stressed? And are you having headaches or anything, any symptoms of anything? Do you have to go to the ER? So that's kind of what we do in the background. That a lot of patients don't realize that we get those alerts to begin with.
Yeah, that is really fascinating because, like in normal, if you saw this patient once every 3 months, that might have happened to him 6, 8, 10 times during the course of that time. Nothing was
Mm-hmm.
done. Who knows what's going on? And it accumulates over time. And it is nice. And, there's a lot of, and as we continue to put resources into the thing, we're going to continue to streamline and better affect how we do these things. So we'll be able to really dial a lot of people in a lot better, which I think is exciting. How much, and like many of our providers, I mean, probably the majority, quite honestly, of our providers, they work their kind of their normal job and then they do Revero kind of part-time on the side.
Mm-hmm.
How does that work for you? Is that a pretty nice mix? Do you enjoy that? You get a break from the grind of
Yeah, I
urology, I
mean,
imagine.
yeah, it's good to and I enjoy it because it's branching out. Because in urology, there's not a lot of blood pressure or blood sugar or med management outside of the BPH and the ED medicines and stuff. So I do it typically. I schedule my availability when I don't have clinic, and that's really the only time you have to be anywhere is when you do an intake call with a patient. But otherwise, I do most of my kind of review of charts and vitals and all that in the evening when I'm home after I've had dinner with the family. I'll come in my office and for an hour or two, just kind of review things and return messages and, chat with patients and, just through the chat feature. And it's really convenient because, it's not going to a clinic where you have to be there on a certain time outside of those intake calls or the calls that patients want to have follow up with. So it's good for folks to kind of one do something outside of what they're doing every day. I'm seeing urology every day, but this is a totally different world, and it is a good quality of life type position too.
Yeah, I think a lot of the providers have commented that it's a good way to practice. It fits their lifestyle a lot better, and it's you obviously you can schedule it to your capacity, so you can
Mm-hmm.
up and down it if you need to, and so that's pretty. Where are you licensed in, by the way? Because are you licensed in a number of states?
Oh my gosh! So yeah, I'm licensed in a lot. I also have another telemedicine job that covers like jail, kind of like an acute care jail type stabilization job, and so
Hmm.
I'm licensed in 19 states, I believe.
Wow, that's quite a
Yeah,
bit. Yeah.
yeah.
Yeah, I remember when I was doing my it's kind of you talk about like inmates and prisoners. When I was doing my surgical training as an orthopedic surgeon in Texas, we had a contract with the Texas Department of Corrections, and
Mm-hmm.
3 months out of every year we would spend working on prisoners, and a lot of it, because of the amount of security that was required to transport these guys, to see them in live. A lot of what we did was telemedicine. And I remember it was in that capacity, trying to do an orthopedic exam remotely with somebody else doing it was hard. I mean, it was just like, it was almost like a joke. And we kind of like, what the hell are we doing? We're trying to diagnose ACL tears without being able to touch the patient. Maybe if you had an MRI, you could do that. But then you're like, do we get an MRI on everybody and then jack up the cost of medicine? So it was like, but it was just like, bringing them in was such an expense because they'd have to travel with,
two guards and all that.
Guards and all that stuff. And so it's just not a good way to do it. I know it was kind of funny. Every year during the Super Bowl, you would always have these guys that would somehow get injured, because they could hang out in the hospital and watch the Super Bowl. That's what
wow.
So they would intentionally, like these guys that could dislocate their shoulders on command, they would just voluntarily dislocate their shoulder, and they're like, I need to go to the ER.
That's kind of like with us. A lot of our patients will schedule their vasectomies around the Masters. That way they can sit around all weekend after their vasectomy and watch the Masters.
Interesting. So you said you've seen some obesity patients, some hypertension. Have you seen any autoimmunity stuff?
There's really, I only have one that's on any autoimmune medicines, to be honest with you. This is actually diagnosed. A lot of people, when they fill out some of their intake forms, will say they have Crohn's or colitis, but during the intake, I'm like, so have you actually been diagnosed, or do you just feel like you have that? Like, no, I have all the symptoms. I'm like, well, you got to have a colonoscopy. You got to have, all the testing to officially give you that. And they weren't on any immunologic medicines. But there is one guy that he has a retina condition that he's on one of the injections every 2 weeks or whatever it is. That's not one that we manage. So he knows we're going to defer coming off that medicine to his rheumatologist or his retina specialist. But I have not had a whole lot of diagnosed immunologic or rheumatologic autoimmune type patients yet.
Yeah, I know we do have several in the community, because I meet once a week with all the patients, or the ones that want to show up. I just have an open Zoom call, and we usually have 60, 70, 80 patients in there, and I just kind of chat. When I've seen a number of them that RA and some of the other autoimmune diseases that we do take care of, and generally they're improving, which is kind of fun to see.
I just haven't had them yet. I mean, it's not like we don't pick and choose who we get. It's just
right for sure. Yeah, and I'm sure you will over time. There's plenty of them as we're getting ready to scale up the company. We're going to do some fundraising, and then we're going to massively start marketing so we can get more and more folks. And maybe I'm sure we'll have to hire some more providers and stuff like that. Let me ask you, so now that you've been exposed to this, and it's probably different than anything you practiced before, how does that impact your day-to-day job? Does it impact it at all? Or does it in the back of your mind, you're like, man, if you just went to Revero, you could.
I've actually given out the website to some patients before who say, who ask about diet stuff and about what can I do to become healthier. Yeah. And I'm like, look, here, I said, I tell them the simplest thing to do. I said, at first I start off, I just say, eat real food. I'm like, if it comes from a package or it's shelf stable, it's probably not what you need to be eating. I said, so, that's my 30,000 foot dietary recommendation for these patients. But I've given the website out to some patients, and, a lot of these patients that are diabetic, it's almost like they've not been told what diabetes is and what it will do to them over time and how to reverse it and get off these medications. So, like I said, I wish I had more time for that conversation with patients. It's just, like you said, we're the only urology group for 4 counties, it seems like. And so we just are, drinking from a fire hose to where I can't have those conversations.
Yeah. Yeah, no, I get it. Yeah, I can remember the same thing in orthopedics. I walk into my schedule, I've got 47 on the schedule, and then my PAs have 30, and I got to see, 20% of their patients because they have questions for me, and then the ER is calling you, and then the OR, you got to do a case in the OR, and it's just like crazy times. So let me add just back to the urology stuff. Obviously a lot of guys, BPH, some guys get prostate cancer, various prostatitis and your UTIs and all that stuff, the kind of run of the mill stuff. What percentage of those things do you think could be, or let me just ask you this. If I, cause I'm almost 60, I'm getting to be an old guy. If I want to have good, healthy prostate function, genitourinary function, what do I need to do to stay healthy?
I mean, I tell all patients, if you keep a normal body weight, that will help everything. Decrease your risk of kidney stones, decrease your risk of not just prostate cancer, but nearly every cancer with a normal BMI goes down. Um, you know, Back to the UTI patients, those that are diabetic, I tell them all, look, your sugar goes down, your UTIs go down. Um, Weight loss, and like I said, it's not a huge focus because we just don't have time to focus on it. But every now and again, we get the guy that's like, "What can I do to be healthy?" I'm like, lose weight because most people carry more weight than they should, and avoid refined carbohydrates. I said that's step one. I don't say eat nothing but meat and cheese and eggs. I say just avoid the fake stuff first, and then you'll be surprised how the pounds melt away, and you'll feel better, and may end up urinating better and have less kidney stones and have less incontinence and better sex life too.
Yeah, those are all important things. Well, kidney stone. Do you guys? I guess a lot. I mean, I would imagine a lot of your practices and up there, it's, grabbing kidney stones and taking people through lithotripsy and putting ureteral stents up and stuff like that. What do you see commonly with kidney stones? And again, I'm not a urologist, but my observation is there is a strong component of metabolic disease overlying kidney stones. Is that a fair statement, or do you guys even care about that?
Absolutely. Yeah. So, once again, heavier people, more prone to kidney stones. The Southeast where I live is called the Bible Belt of kidney stones too, because we tend to be less healthy than out West and Northeast and stuff like that. In folks who have kidney stones, we do have a metabolic discussion about dietary things that can contribute to the stone formation. There's certain dietary things we recommend folks to limit. We recommend folks to drink more water, avoid, the high oxalate stuff. Everybody asks, oh, am I supposed to have a calcium stone? Can I not eat calcium, cheese and dairy? And they think all kidney stones are from calcium or too much meat protein intake and things like that, which it's not really. It's not at all, actually. I had a guy today that he had a kidney stone 4 years ago. He said, I quit eating dairy. I said, that's the worst thing for you to do because that dietary calcium actually binds the oxalate in your gut, and meat has zero oxalate, and 87% of kidney stones are calcium oxalate, and it's almost always the oxalate in the diet and not the calcium. Every blue moon will find somebody who has a parathyroid adenoma that's secreting too much parathyroid hormone that's running their calcium level through the roof. But that we see that 2 times a year. So, like I said, 99% of kidney stones is higher oxalate, from high oxalate diets. It's a lot of metabolic discussion with that stuff.
Interesting. And given your, the recent time with Revero, has that sort of rubbed off on any of your colleagues? I mean, do you guys discuss any of this stuff, or do they just think you're the nutty guy that eats meat? And
no, I mean, not really. They know I try to, especially, you remember back when you were in private practice, drug reps coming there and tempting you with lunches and all that kind of stuff. And they'll see me, they'll pick the meat and the cheese off the sandwich and just eat that and not the bread. And, I have patients ask me what I eat, and I tell them, and I'm like, and it works for me. And I lost 25 pounds on it and things like that. And my cholesterol got better. And they're like, your cholesterol went down by eating bacon and eggs and ground beef. And I was like, yep, it dropped a lot. And it's kind of, it's counter to what, the food pyramid has been telling you since kindergarten. And it's just confusing to folks.
Yeah. Well, because you mentioned the Southeast, and there is a lot of obesity, from Mississippi, west of Mississippi, east of Mississippi. It goes, well, hell, half the country, most of the country, quite honestly.
Right.
But it does seem to be that maybe it's all the sweet tea and pecan pie and whatever, peach cobbler, what else is being eaten down there. But anyway, well, David, it's been a pleasure chatting with you. It's good to get to finally talk to you in person. Keep up the great work. Thanks for being part of Revero, and thanks for helping make a difference and changing the way we do medicine. Thank you so much.
Yeah, thanks. Good time.